next, we have Dr. SUSHMITA KAUSHIK. She's going to speak to us on the newest baby in glaucoma management, MIGS, a reality.
This side?
Yeah. Dr. Chandrima, please.
Good morning, and at the outset, I thank Dr. Chandrima for inviting me to this exciting course, and thank you for letting me speak early. So, coming on to MIGS, or minimally invasive glaucoma surgery. Surgery is always an attractive, one-time magic wand, but it does have risks and complications. There's an issue of adequate training for glaucoma surgery. It's not a quick fix solution. The post-op management is more difficult than the surgery itself. And you do have the problem of scarring, failures, and many, many failures if followed up long enough. To top it all, the patient has a false sense of complacency that the surgery has been done, so probably his glaucoma is cured. So the problems with the trabeculectomy are the propensity to fail by the scarring of the bleb. Excessive filtration could lead to choroidal detachment, hypotony, and there is a lifelong risk of a bleb leak and, of course, infections. Children are a different challenge altogether because it's not just pressure, it's vision, and indeed a whole lifetime to take care of. So ab interno procedures for them to protect them from opening up the conjunctiva are desirable. So the new thoughts worldwide is to spare the conjunctiva, and that's what minimally invasive surgery promises to do. There's minimal disruption of the conjunctiva, sclera, and iris. There are angle-based surgeries which bypass the abnormal trabecular meshwork, and translimbal surgeries which bypass the normal aqueous outflow, and there are some which also have a conjunctival filtering bleb. However, none of them precludes further surgery, so it's not a one-stop surgical answer in any case. So let's break it up and look at the options that we have. So you could have an angle-based MIGS, you could have canal-based MIGS, and you could have a translimbal fistulizing MIGS. So the angle-based ones which are possible for us to do and which are available in India are a goniotomy, a BANG, a bent angle needle goniectomy, a GAT, a gonioscopy-assisted transluminal trabeculectomy, and a trebektome. So these are things that we can do to the angle. You also have the Trabex and the KAUSHIK dual blade, which is yet to be marketed in India. The canal-based ones are the ones which target the Schlemm's canal, which is the eye stent, but also the hydrus and canaloplasty, which again are prohibitive in cost and not available. What is exciting is the Zen and the pressor flow microshunt, which are microsurgeries, but are translimbal fistulizing as well. So it's a safer trabeculectomy to do. Now, the prerequisites for MIGS are, of course, a direct gonioscopy. You need to understand the microscope and head position, and you need to rotate the head of the patient to the opposite side. So the microscope needs to be tilted at one direction, the patient's head needs to be on the other side, and slowly you need to put in the lens on the cornea for you to be able to see. So these are really the prerequisites for all MIGS. I'm showing this in a baby who we are planning a goniotomy, which really is the mother of all MIGS, as it were. So this is the surgeon's position with the microscope tilted. This is my senior resident Ashok, who's doing a bang actually. The head is tilted to the opposite side, and the surgeon sits directly opposite the angle to be operated. And this is while he's operating the right eye, and you can actually see it on the monitor, his instrument going in and treating the angle. So goniotomy, we started out with a couple of years ago. It's just slicing the trabecular meshwork. An MVR blade is being used here. And this is the cleft that is forming. And as we go ahead, you'll see that is the treated, and that's the untreated area. So is there a pointer somewhere by any chance? Pointer here? Okay, so that's the untreated area which is being treated, and you can rotate the globe and go as much as you can in both sides. This is a patient with Axenfeld. You can see the untreated and the treated angle with the cleft which has opened up, and the iris falls back. So the bentangle needle goniectomy, or the BANG, has become very popular. It's an extension of goniotomy, except that a strip of the trabecular meshwork is excised rather than sliced. And thank you. It's the same principle as the KAUSHIK dual blade, but what is being used is just a 25 gauge needle which has been bent at the tip, and soon you will be seeing the strip of trabecular meshwork that is coming out. So this, on the tip of the needle, what you see is the excised trabecular meshwork. This is it. So this is the trabecular meshwork which has been excised, and we're using it quite frequently while doing phacosurgery for patients with glaucoma. The next is the trebektome, which is also similar to the BANG, except that it uses plasma energy rather than mechanically stripping it. And apparently, it is better to ablate the trabecular meshwork. So you can see the plasma energy and the bubbles that are going. Of course, essentially, the trabecular meshwork is ablated rather than cut and excised surgically. The gonioscopy-assisted transluminal trabeculectomy is a 360-degree ab interno trabeculectomy. This is a patient with Axenfeld who came with very high pressures. So short of doing a trabeculectomy, we thought, let's try a BANG first. They work very well. This is a bit of a thing which could be avoided. We've made the first incision for the proline a little towards the limbus. So that was the bit of heme that you were seeing, which is under the lens. But once you identify the schlemms, you just need a vitrectomy. We use a max grip forceps, but any micro forceps can be used. Once it goes out the other end, you've grasped one end of it, the other end is outside, and here you see how the proline is slicing out the trabecular meshwork from inside. So it's actually just two little ports into the eye, and your surgery is done. So how does MIGS fit in? I'll just show a couple of cases, what we do in real life. In children, it's been a game changer for us when we don't need to open up the conjunctiva. Even with reasonably hazy corneas, if you can just visualize where the iris is inserted. We've just published a large series in the IJO a couple of months ago, and most of our children, thankfully, are doing very well. Some of them require a second. And we also do it in failed trabeculectomies as the first step to treat the rest of the angle, and they do quite well. Any patient with cataract and glaucoma now, we are combining with a MIGS. Now, the best case scenario is a moderate glaucoma in open angles, of course. So, for instance, this woman who was POAG, 624, 618 vision with cataract, 16 millimeters of mercury on a prostaglandin analog, 0.8 cups, and an NO3 and PSC in the right eye. So this is a typical case of moderate glaucoma on medication but controlled, reasonable, moderately damaged optic disc with a cataract. So this is what we do with the routine phaco. We take in the needle, we first do the BANG, that's the bentangle needle goniectomy, and then follow it up with a routine phacoemulsification. So once this is done, we use that as a side port. You can use that as a main port, but I find it more controlled. So this is actually the trabecular meshwork, this strip here, which is stripped off. This is the port of the BANG, and this is the usual phaco port. So as you would do your phacoemulsification, you just proceed with surgery, put in your lens, hydrate it, and actually you've done phacoemulsification and glaucoma surgery in no time, and this is under topical anesthesia. So for us, it's been value addition in that sense, and this is on the first post-op day. It's been about a month now. She's still 10 millimeters off her drugs. So far, so good. If it works, there's nothing like it. In pscg, surprisingly, yes, even though everybody says, and the textbook teaching is minimally invasive surgery should only be for open angles, but with the load of pscg that we have, angle closure. So this, for instance, is a 65-year-old man, and this is how we think about how to approach a patient now. He has a patent LI in both eyes. The pressures are 22 and 16 on 3 medications. He has ISC with both eyes, but the right eye is more advanced than the left. So the thought process was his pscg, let's combine the right eye with a bit of MIGS if possible, and let's just do the cataract surgery in the left eye because the disc didn't look so bad. So he underwent a right phaco-trebektome, And post-op 6 months, the intraocular pressure is 10 millimeters off drug. So that's quite magical at times. I mean, somebody who is 0.9 cup on 3 medications, and you're thinking in a couple of years you might do a trab. But we just stripped off the trabecular meshwork, and it's actually worked. And on hindsight, I think pscg will work better because the outflow channels are more likely to be robust, because it's a trabecular meshwork which is problematic because of the chronic closure. The left, we did only a phaco because we thought that the pressures were better, just 16, and the disc wasn't so bad. And this eye also at the same time is 12 off drug. So far so good. We'll take it as it comes, but about the 6 months to 1 year data of the patients that we do, and this is completely anecdotal, is we are quite happy with it. Can we reduce medications? This is another 64-year-old woman, primary angle closure glaucoma, trab done since 9 years, and the pressure is 18 on Diamox and 4 meds. So what are the options we have? Bleb revision, trabeculectomy, tube, or maybe we can try a MIGS. So we tried a trebektome as telling the patient that it's just one stop short. I'll just take 30 seconds more. So one stop short of doing something, and you can see even in a primary angle closure, even though it is closed, if you can just get through the behind the iris and find your plane. And why we chose a trebektome was because I thought it was chronic angle closure, and with the plasma ablation, it might bleed less. I was a little scared that with a bang, it might bleed. So you can go both sides, and you can see that trabecular meshwork being ablated by that. And POD1, so far so good. In fact, a little bit of the bleb seems to have opened up as well. And as we went down, it's 3 weeks yet. But so far, it's just 8 millimeters off drugs. We haven't touched anything else. She has a clear lens. I haven't touched her lens. So that's possible for me in the future to do that. But sometimes even this can. So I'm a little conservative about taking out clear lenses simply because the pressures are high. I don't believe that is a work, but I don't mind doing a MIGS for them. Sometimes when you want more than a goniotomy, but you don't want to do a CTT, especially in children. So this boy, for instance, obviously the right eye is more damaged, it's more ophthalmic, 28 pressures. So we did a GAT in the right and a goniotomy in the left. So a 360 in one eye and just about half in the other. And so far so good, he's stable, the pressures are normal in the others. I have the advantage of knowing that I have the rest of the angle to treat in the left eye should I require it, but usually what I have seen is we don't require it. Again, GAT surprisingly worked in pscg. Now this is on 5 medications, laser iodotomy done, very shallow AC, again clear lens. So my problem is taking out clear lenses, and actually I went ahead and did a GAT in her. So disc had an inferior notch, superior field effects. First post-op day, bad hyphema. So I was telling myself maybe this wasn't such a great decision. But this hyphema cleared. We did it in March last year before the COVID again raised its head. And she's just come to us, and this is a very recent picture, but she's still 14 millimeters off drugs after not putting any drugs in all this while and being lost to a COVID thing as well. So early days yet, but I can share my preliminary thoughts. Children, if you can see the angle, even if there's a haze, yes. Goniotomy, bang, GAT, trebektome, whatever you have, please treat their angles because it's an angle anomaly. Planning cataract surgery in a patient with glaucoma, even pscg, yes, bang is the easiest. At least reduce or wean off medications in moderate to early glaucoma, and you might avoid incisional surgery in advanced glaucoma, but the point is there's no harm. If you're going in to remove a cataract, add a MIGS with it, and you won't be doing much harm, you might end up doing good. If it's a clear lens, my thinking is a trebektome would have a less bleed, and if it's POAG, you do anything because the angles are open, it does reduce medication burden. I acknowledge all my team who's helped me put this two together, and thank you for the opportunity again.
Thank you very much, Dr. SUSHMITA. As usual, a very informative and illuminating talk with beautiful surgical clips. If you have a question for Dr. SUSHMITA, you could ask her right away because she would be leaving for another hall. Yes, please.
I think you'll have to switch on the mic.
how about MIGS and Sturge-Weber syndrome, ma'am? Does it work?
Logically, it shouldn't because there is a raised episcleral venous pressure. So difficult question. I would try because you don't want that much of a pressure lowering. But Sturge-Weber is a bimodal thing. So I would say that in that young Sturge-Weber, a young adult, 16, 18 years old, it's unlikely because the mechanism is raised episcleral venous pressure. But a Sturge-Weber baby, it's going to work very well because there it's a trabecular dysgenesis. So if it's less than 3 years, a young child, I would do it. Older, I would do it anyway. My take now is to tell the patient and the parents, look, it's not going to do any harm. Prepare them. I might have to do a more risky or invasive surgery, but let us go stepwise. And I tell them, if you can kill somebody with a bullet, don't use a cannon. Nah? The cannon will kill him, but let's try the bullet first. That's what I tell them.
Thank you, ma'am.
Can I ask a quick question,
Yeah.
Dr. Sushmita? When you do phaco along with, say, bang, is there a particular reason why you prefer to do it before removing the cataract?
Yeah, because I've done both, but I've always found that MIGS is always better if you do it in an unopened eye. It's more predictable. Removing the trabecular meshwork is easier. You know, once you've opened it up, done your cataract, put it in, then the eye becomes somehow very floppy and it's not as responsive as you would like it to be. And sometimes when you then decompress it, sometimes the lens optic comes out of the CCC, then you have to tap it back again. You disturb because you move the head. And since they're under topical, then with 3 holes, it gets a little more difficult to. So doing it under topical, if you just have one small port, do your MIGS, finish it up, come back, and then you're. So I found it better, but there's no reason why you can't do it without, doing the phaco first.
Only thing is that I suppose you've got to maintain less turbulence in the anterior chamber when you're doing your phaco. Post inserting.
Nothing happens. It's not like a trap. It stays pretty much okay.
Not like that it'll be dislodged or
And
something.
I think the other advantage with doing a phaco later is that you wash off all that muck and allow all that fluid to go out into that newly created cleft. So when you're doing your IA and you're doing everything is just being pushed out of the eye. You can actually see that white band outside and you know the collector channels have opened up and it is gone. So I personally find it easier. I do my MIGS before the phaco. And it doesn't matter if it's dilated. It makes no difference.
Thank you very much, Sushmita.